We now turn to our healthcare panel, and that will be moderated by Laura Stock. Laura Stock, a colleague from the California Labor Lab, is the director of the Labor Occupational Health Program at UC Berkeley, one of the unique organizations in the country. She directs and administers LOHP's programs providing training, research support, materials development, technical assistance for workers, employers, health professionals, and the general public. Laura is a member of the Cal-OSHA Standards Board, charged with developing occupational safety regulations for the state of California, as well as the NIOSH NORA Committee on Healthy Work Design. And I really enjoyed the several years now that I've worked closely with Laura and learned from her all the time. Laura?
Thank you so much, Ed. And thanks for arranging this conference and this panel. As Ed said, I'm Laura Stock. I'm really honored to be able to share this panel with our participants. I want to thank Dr. Frogner for a great presentation that did an excellent job of setting the context for the discussion that we're having. As everyone has said, the pandemic definitely shone a spotlight on the stresses faced by healthcare workers, including issues such as understaffing, burnout, lack of protective equipment, et cetera. But we all know that these have been going on for many, many years. And I appreciate the presentation that put that all in the larger context. And we're really lucky today to be able to have an opportunity to hear from some people on the front lines of that situation, who can describe their experiences and some of the changes that they're advocating for, as well as some researchers who are looking further into the experiences by different sectors of healthcare workers. So I'm going to do a brief introduction of all the panelists, and then just to let people know what's coming, I'll start by asking panelists to introduce themselves and talk a little bit about the work they do, how they may have seen it change over the last number of years, and what they see as the key issues that are facing healthcare workers from their perspective. And then after we have that general opening conversation, I'll go back to everyone to ask them to focus on what they think, what solutions are needed, what sorts of strategies should people be taking to improve working conditions, and any call to action you might have for participants. So first, let me introduce our panel. So we have joining us Jane Thomason, who is a certified industrial hygienist and the health and safety coordinator with National Nurses United, which is the largest labor union and professional association for registered nurses in the United States. And in her role, Jane oversees health and safety literature and policy review, and teaches continuing education classes for NNU's over 225,000 RN members. She has developed expertise and conducts research on a wide range of issues faced by nurses, including violence, ergonomics, patient handling, infectious diseases, and other hazardous exposures. And she has been in the forefront of advocating for better protections for healthcare workers for many years. Next, we're going to be hearing from Constanza Nider. She is a unit secretary and interpreter in the emergency department at Palomar Health. And she works in San Diego County, and she's a member of the Caregivers and Healthcare Workers Union, CHEU, and is a member of the 2024 negotiating team for her union. So looking forward to hearing from Constanza. Then we'll be hearing from Jessica King. She is a research and evaluation associate with a Public Health Institute, and she specifically worked on building the evidence base for state and national policies and workforce interventions that improve the quality of life for direct care workers. She specifically has done work looking at long-term services and identifying needed supports for older adults and people with disabilities. She's worked in a variety of settings within healthcare, as a social worker, including residential care, community mental health, etc. And she focused her recent research on workplace policy and the experiences of working women who served as family caregivers to older adults during COVID-19. And then we'll hear from Marnie Dobson, who is currently the director of the Healthy Work Campaign and the program director of the Center for Social and Epidemiology, which is a nonprofit organization and sponsor of the Healthy Work Campaign. That campaign focuses on raising awareness about the impact of worker stress on worker mental health and physical health. And she's been a researcher for almost 20 years in occupational health focused on work stress and mental health. And she's recently studied the impact of the pandemic on public health the public health workforce overall. And then we will also be happy to welcome Dr. Frogner back to join us as well to offer her further perspective and give her a chance to respond to questions as they come up. So with that, I'm going to start by turning it over to Jane and asking you to spend a couple of minutes to describe a little bit about the work you do and what you see, how healthcare jobs have changed, and what you see that some of the biggest challenges workers are facing now.
Thanks so much, Laura, and hi, everyone. As Laura said, my name is Jane Thomason. I'm an industrial hygienist for National Nurses United and the California Nurses Association. NNU is the largest and fastest growing nurses union in the US, and CNA is our largest state affiliate. So in my role with the union, I support our members in their advocacy for safer working conditions. And when it comes to key issues that nurses are facing right now, I know we're trying to stay to just a couple of minutes each. But I think, recognizing that the pandemic, as Laura said, and others have said all day today, the pandemic has really revealed how indifferent corporate healthcare is to the well-being and the safety of nurses, other healthcare workers, and patients. And even to this very day, employers in the healthcare industry continue to resort to crisis standards of care instead of protecting and retaining nurses and other workers through safe staffing, fair working conditions, safe working conditions. And I think that is a really fundamental issue that underlies a lot of the other issues that, we could name that nurses are facing, which we should name. But just to point that out, I think up front, that focus on profit is a really significant issue that nurses are facing right now in the healthcare industry. And in terms of how it shows up in other issues, I think we can talk about workplace violence. NNU conducted a national survey last year on workplace violence, and we found that nearly half of nurses report an increase in rates since the beginning of the pandemic, and that healthcare employers are neglecting even the most basic of prevention measures. Just to take one example, only 30% of nurses reported that their employer has staff available at all times to respond to violence, something that's really basic. And as a result, nearly 2/3 of nurses in our survey reported having left or considering leaving the bedside or the profession due to workplace violence. I think, just to move through some other issues, looking at infection control, I think everyone's aware, especially since the pandemic, that that's a significant issue in healthcare. Earlier this spring, NNU conducted a national survey on infectious disease protections, and we found very similar results to our workplace violence study. Only about 1 in 10 nurses report that patients are always screened for respiratory infectious diseases and isolated in a timely fashion. And when it comes to PPE, we saw so many issues early in the pandemic, but there continue to be major issues. Just to take one example, only about 2/3 of nurses report that their facility uses a respirator for tuberculosis and COVID, both of which are known to transmit through the air and definitively require a respirator. And I think the other piece to call out at the beginning of our conversation around infection control is that we are currently seeing the industry try to weaken guidance for infection control at the CDC level. There's just really briefly, I know many folks have been following this campaign, but there's an industry-dominated committee, an advisory committee at the CDC that's called HICPAC. And they proposed draft guidance last November that basically it ignores a lot of the science that we know about infectious disease transmission. It says things like healthcare workers should wear surgical masks as protection for pathogens that transmit through the air, things like COVID. It proposes to start with lower protections in the next pandemic. There are a lot of issues with what they've proposed that really seek to weaken protections for healthcare workers. And, nurses have stood up. Nurses with NNU sounded the alarm when these changes were brewing. And because nurses organized with their allies in January, we were able to get the CDC to send the draft back to HCPAC to address some of our core concerns. And there's been, some more work trying to push the CDC to add additional experts to the work group, right, to expand it outside of industry. But I think the bottom line here is that industry is really trying to weaken the standards to which they are being held, even on the heels of this crisis, where we saw the impact of what having weak standards was on the lives of healthcare workers and patients. And I think the other piece to call out as context at the beginning of this conversation is that healthcare employers at the same time are decrying a nursing shortage, which they are saying is preventing them from safely staffing healthcare facilities and implementing health and safety protections like workplace violence protections. They say that this nursing shortage, the so-called nursing shortage, is a crisis that's demanding continued regulatory flexibility and lowered standards. But I think the reality that everyone needs to be in touch with is that there's no shortage of nurses. Nationally, there are more than 1 million licensed RNs who are not currently working as nurses. Just in the state of California, there are about 150,000 licensed RNs who are not currently working as nurses. And so the reality is that there's a staffing crisis in healthcare as nurses, and this is true for other healthcare workers as well, are no longer able or willing to work under these conditions imposed by their employers that risk their safety, risk their licenses, and the lives of their patients. And so what's happening here is the healthcare employers they're using the COVID pandemic, they're using the staffing crisis as excuses to implement changes that ultimately boost their profits and bottom lines. And that's happening at the expense of healthcare workers and patients. I just want to provide one example of this, and then I'll wrap up my piece and let others weigh in. But one example is, I think, with the rapid influx of new technologies, many of which are utilizing artificial intelligence and into the healthcare industry. And in many cases, employers are implementing these new technologies with very little oversight and essentially no transparency. And they're doing it in ways that are displacing nurses from the actual physical care of their patients while prioritizing low cost or even free labor over patient needs. So take one example of these new technologies, remote monitoring, where instead of having a staff member tracking a patient's condition, there's one person off-site who is watching the monitors for 10, 20, 30, or even more patients at a time. And that has real ramifications for those patients who are no longer getting the nursing care that they need. The algorithms that these technologies are based on are known to be biased. Many of them are wildly inaccurate, and they often reinforce racial disparities. And there's also, of course, implications for the safety of the nurses and the other healthcare workers who are working in these environments. Algorithms can never replace a nurse's experience and judgment when it comes to, say, helping patients de-escalate to prevent workplace violence. And this is also happening, in the midst of employers pushing other schemes like magnet designation, national licensure compacts, gig nursing, right, as so-called solutions to the staffing crisis. But the reality, I think, is that these schemes only boost their profits, and that's happening at the expense of nurses and patients. So I can leave it there on some of the major issues, and I know we'll get into more details in our discussion. So thank you.
Thanks so much, Jane. And thank you for making that connection between degrading working conditions and degrading quality of patient care. It's a really important thing to remember. So thank you. And yeah, we'll come back to you later to hear a little bit more about what your perspective is on what we need to be fighting for now and sort of more about current campaigns. But now I'd like to turn it to Constanza Nider. I'm sorry, I don't know if I'm pronouncing your last name properly, whether it's Nider or Nider, please correct
It's
me.
Nider.
Nider, thank you. I'd like to turn it over to you to talk a little bit about your work and what you've seen and how things may have changed and what are some of the major issues you think people in your position face.
Again, my name is Constanza Nider. I'm one nursing unit secretary for Palomar Health in San Diego County. I am a member of the Caregivers and Healthcare Employees Union, the CHEU, and I'm on the bargaining team of our negotiations for the year 2024. CHEU is an independent union formed in 2001 by healthcare workers who wanted to represent alongside the CNA, which is our sister's union. That's the nurses union. And our goal is to get a strong union representation to improve the conditions of the employees and the patients. Our number one goal is to improve the safety of in general, the hospital. I have been in healthcare for about 30 years. I started as an interpreter, a Spanish interpreter. And the last several years, they decided to change it because apparently we were a unused source. So because we sat down, for periods of times when we didn't have any Spanish patients, Spanish-speaking patients. So they decided to combine our role with being a nursing unit secretary. So I had to doing my secretary work and do the interpreting as well. A couple of years later, they decided that wasn't enough, and they had us do via teletech. So we had the cardiac monitors on the desk, doing the secretary work and the interpreters. Now, keep in mind that the cardiac monitors, we could not leave the desk, but we had to do interpreting as well. So being a secretary alone, we had to answer phones. We had to call doctors for the doctors. We had to do faxing. When you do faxing, you're facing away from the monitors. There's a lot of roles that we had to do, and being short-staffed, we would not get the breaks that we needed. We couldn't go to the bathroom when we needed to because there's the monitors right there. This is somebody's life that we're looking at. So as soon as we saw a change, we had to tell the nurse or the doctor. And if we're on the phone, we had to cut the phone call and, to do the appropriate action that we needed to take. There was a couple of people that they decided that they were done with it. So they went to another position because they were having health issues because they couldn't go to the bathroom when they needed to. I was even one time, I almost got written up because I couldn't wait anymore. I went to the bathroom. My supervisor saw me and called me in the office to give me a write-up. Thanks to the union, we came in and we fought it, and I didn't get a write-up. But we kept on fighting, we kept on fighting, we kept on fighting. And they finally decided to put the monitors in one room. So now we take turns into doing the tele room plus the secretary. So we just rotate, even though I still have to do the interpreting, but it's a little bit easier. But nevertheless, we are always short-staffed. So I just think that our employer doesn't give us as much. They want us to give them all this work and all these efforts, but they don't put any efforts back. And by cutting staff and combining positions, it jeopardizes not only our health psychologically, physically, and mentally, but the health of the patients. So, that's why I got involved in the negotiations team, because what we want to do is create and fight for a safer workplace for our democracy and justice.
Thank you so much. For sharing those stories and for the work that you're doing now to try to improve conditions, not only, for all of your coworkers, and look forward to hearing more about what you might be demanding as part of your negotiations when we come back to you in a little bit. But thank you so much for participating in this panel. And now I want to turn to Jessica King. If you could share your perspective of, what you've been working on and what have you seen as the major challenges faced by healthcare workers.
Yes, thank you, Laura, and welcome. Good afternoon to everyone today. So I work for PHI. It has the same acronym as Public Health Institute, but actually we're a different organization. We're based in New York City.
My apologies.
It's okay. The two get mixed up often. So I'm a research and evaluation associate, and PHI is a national nonprofit that takes a 360-degree perspective on issues facing the direct care workforce. So specifically home health aides, nurse aides, personal care aides, and direct support professionals, among others. And PHI believes that quality jobs are the foundation for quality care. So we work to strengthen the direct care workforce through research and evaluation, policy advocacy, and workforce interventions and training. So what we think of are basically 8 main challenges that fall into kind of distinct categories. So I'll name those 8 distinct categories that we really are focusing on in our work at PHI. The first is inadequate public investment, so particularly regarding Medicaid. Medicaid is oftentimes the payer that pays the direct care workforce. Many of them are working as part of Medicaid waivers, and the reimbursement rates through Medicaid are just insufficient. This ties in with overall insufficient compensation. So again, that is inadequate public investment is directly tied to the insufficient compensation. Inadequate training and training opportunities for workers. So many of these workers come into the role and they're given very little training. Only home health aides and certified nursing assistants actually have a federal standard. Other roles like personal care assistants or personal care aides, the title varies depending on what state you're in. There's no federal standard. So for example, if you're in the state of Vermont, there's no training that you're required to do. So you're just sort of thrown into the role. You may get an orientation by your employer, or you may not, but there's no federal standard for training. And even the federal standards for home health aides and CNAs or certified nursing assistants, those are insufficient. So there needs to be better training. Another issue is the lack of career progression or professional growth for workers. So we talk a lot about the lack of career ladder. There's limited opportunities for promotion. And so many workers feel stifled in their roles and like there's nowhere for them to grow professionally. Workforce shortages, similar to what Jane discussed. So understaffed facilities, overworked direct care workers because they're handling more patients than they safely can handle just because there's not enough workers. There's high levels of burnout, as we've all talked about, exacerbated by the pandemic. And the work is very physical. It involves a lot of manual turning of people and transfers. And so it can have a really big, take a really big physical toll on direct care workers. It's actually one of the most dangerous jobs in the United States. Another huge issue is the lack of respect for the position and negative representation of direct care workers. Workers do not feel valued, and they're often left out of policy discussions that directly impact them. The next one is insufficient data and data collection practices. So when we talk about the workforce shortage, we can't actually measure that accurately right now because we don't know how many direct care workers there are. There are national surveys like the American Community Survey that we can draw data from, but even that is missing data. And so these data collection practices, again, there's no federal standard for it. They're disjointed, they're underdeveloped. In 2009, a federal report was commissioned that recommended a minimum data set for direct care workers. And here we are 15 years later, and even that minimum data that we found in 2009 that should be collected is still not being collected. And actually those recommendations need to be updated. The final thing I want to discuss is the systemic oppression, marginalization of workers, specifically in the forms of racism, sexism, and xenophobia. This workforce is largely women of color and immigrants. It has been persistent in the workforce for as long as the workforce has been in existence. The low quality nature of these jobs is rooted in the systemic oppression of the identities of the people who hold the jobs. And then there, of course, are the negative and punitive policy climates on immigration that have added further hurdles for the workforce.
Thanks so much, Jessica. Those are really important issues. And again, look forward to coming back to you in a few minutes to hear about some recommendations you might make. So now I'd like to turn it over to Marnie Dobson to share your perspective.
Thanks so much, Laura, and it's lovely to be here. Good afternoon to everyone. Yeah, I am also a researcher. I've been a psychosocial occupational health researcher for some 20 years, working through the University of California, Irvine with colleagues in occupational epidemiology. We've done a lot of fieldwork studies. My PhD was in sociology, so I was very interested in, direct work with working peoples to, hear their voices, to understand what's going on. So I really value the work that you're doing in this conference and hearing directly from workers and worker representatives from their unions as well. It's so important. I am currently the director of the Healthy Work Campaign, which is a project of our nonprofit Center for Social Epidemiology, which is a mouthful, but the CSE is a nonprofit that's been in place for almost, over 30 or 40 years now. My colleague, Dr. Peter Schnall, is the executive director, and I'm the program director. The goal of the center was really to translate what we know about work stress prevention and work stress, the science of work stress and its relationship to population health. We know that there's a lot of scientific information out there about the impact of work stress on health, and especially mental health, but also cardiovascular health. We started the project in 2019 not as a research project, but as a service to working people, to organizations, and also to unions that we work really closely with. And really the goal is to try to offer tools to measure issues that are going on in the workplace. For example, work stressors, sources of stress at work, including many of the things we're talking about that are evident in the healthcare workforce, like high workloads, conflicting job demands, work-family conflict issues, obviously long work hours are major concerns, also workplace violence and other workplace injustice issues around workplace bullying and discrimination in the workforce as well. These are all factors that we know scientifically have been related in large population studies to poor mental health outcomes, to burnout, and so on. Back in 2022, just as the pandemic was kind of tailing off a little bit, we were approached by a public sector health and human services agency, and they were really interested in working with us. They had a very, as the contact I worked with, who was a public health nurse, said they're a very demoralized and burned out workforce. She had worked in the public health branch. There were 5 branches in this organization, which included a lot of, healthcare workers that did work with, they had a child, youth, and family branch, adult and aging, as well as service center workers who, helped with eligibility programs, with employment services, helping people to apply for access to, different welfare programs. Obviously, during the pandemic, these needs grew, especially for public health workers. Public health nurses were out there in the front line, dealing with the effects of COVID, as well as the social community and social service workers who were dealing with a lot of need from loss of jobs, obviously from people who were ill and needed support. So it was a pretty, obviously for all healthcare workers, it was a major stressful event. The organization, the agency that we worked with, were aware that this was going on for some time, even way before the pandemic. And I think this one particular champion was really ready to do something about it. And she'd been investigating sort of a total worker health approach, had reached out to us to see if they could use the online survey tool that we developed that measures these elements of the workplace, so they could get a sense of the extent of these problems in kind of real numbers. So we did the survey with all 600 employees, and the employer gave some time during an all staff meeting for staff to complete the survey, which is kind of long. But the bottom line was, they were able to show, very high percentages of high workloads and job demands up around, in some branches, up over 60% in the very high score range, much, much higher than the US average. There were issues going on around workplace bullying, which they were very surprised about, and also workplace discrimination, especially in terms of gender and race, ethnicity, predominantly a female working population. About 30 to 40% were Hispanic and Latinas. There were some 30 to 40% white, and about 5% African American, and around that as well for Asian Americans and some Native American workers as well. So there was some disturbing experiences, when management started to look at the numbers. They were disturbed by the reality of of these workplace bullying numbers, which were, up around 20 to 30% of people that were reporting workplace bullying, around 10 to 15% reporting discrimination on the basis of gender and race, ethnicity. And we can talk a little bit after this about, what they were willing to do about it and what the constraints were, because it has a lot to do with the, what kinds of changes can take place. We reached out, actually the management reached out to the unions, and we were able to share data with their unions. They had 3 different unions there. And I can talk more about the effectiveness of this particular strategy after this. But
thank you so much. And yes, and finally for this first round, I want to turn it back over to Bianca Frogner to see if you have more you'd like to add in terms of what you see as the key issues. And just to say, we are hoping to leave some time at the end for questions. There's 1 or 2 that have come in that are related to the issues that people are facing that I may pose, right after we hear from our next speaker. But then we're going to, as I said, go back around and give everybody a few minutes just to talk about what they think their biggest recommendations for action should be. But yes.
Yeah, thank you,
Frogner.
Laura. Yeah, and I know I've had my share of time earlier today to outline kind of who I am and what our center does, and I'll just briefly just summarize in case anyone may have missed it. I direct the Center for Health Workforce Studies, and that's housed in the University of Washington, and we can certainly conduct a number of studies across a wide range of healthcare workers across multiple settings. And I think want to emphasize one point, which is a lot of times we do try to find research questions in collaboration with partners who are actually on the ground doing the work, whether that be health professional organizations, whether it be with our state workforce board, whether it be actually hearing from the workers directly and engaging them in our research, because I do think it's very important for us to address questions that are actually going to improve something in their lives rather than produce research that just sits somewhere on the shelf. And I think that is something, at least in the research community, that especially in the public health space, the medical space, is recognizing that we can't produce this research without working together with the workers themselves to understand kind of what are the primary issues. Can't say everyone does this, but I think there's certainly a movement toward recognizing that importance of hearing their voices in the work that we do. I think over the last several years, particularly with the pandemic, I'm encouraged by the fact that there's this recognition of the broad spectrum of people who work in healthcare, and that there are many shared concerns across multiple of the occupations, and that perhaps are going to be stronger by working together to fight for certain things that are actually beyond maybe what an employer themselves may be willing or able to provide. So for example, childcare is certainly a top priority that we're hearing across multiple health professions, because again, this is a very female-dominated field. A lot of people have children who work in healthcare, and that we need a more coordinated effort to try to get affordable and accessible childcare to people, and that this is not just a healthcare industry challenge. This is a challenge across all employers, but particularly it should be a priority for healthcare, given how female-dominated of a field it is, and that we need to work together, encourage employers to be advocates, to be involved in policymaking, to go after encourage our politicians to invest in childcare and make those bills come to light and get voted through to provide the services and supports that employers may not be willing or able to provide that kind of service out of pocket. Because there are many smaller employers in the healthcare industry who do not have as many resources available to provide affordable childcare, let alone health insurance. And so we need to figure out how to equip those employers to be more proactive in their local politics to get the resources that they need. And I think as part of that is this hopefully growing recognition due to COVID that healthcare workers are workers. These are jobs. There's nothing so special per se about healthcare workers. I mean, these are very dedicated people, but we cannot rely on their dedication to help others as a way to say, and therefore you should just accept these conditions that you have because you're caring people. No, they're workers who have needs, family needs, personal needs, and we need to address those needs. So I think I'm hopeful that some of that is becoming more clear, I think, to employers, that they can't just rely on goodwill alone of the workers just to be there, that we need to actually address their needs. So I'll stop there.
Thank you so much. And so I wanted to, as I said, I wanted to go around now to give everybody a couple of minutes. We have until 2:45, and so we're going to try to do this in about 15 minutes or so in order to leave time for questions. But I thought I would pose one question that did come up because it's directed to Jane, who is the next person who I'm going to turn to now to talk about recommended actions and strategies, which was related to, the question was, have you noticed disparities in infection control protection for nurses versus other healthcare workers, such as lab workers, physical therapists, or physicians? And so how do you see this disparity? So that's a little bit relating to the work about what's the scope of the problem. So if you have a comment on that, and then if you could just highlight for us what you think the key strategies and demands that either you're working on and you recommend that others advocate for.
Great, thanks, Laura, and thanks for the question. Just in terms of the data that I was sharing earlier, that survey was just for registered nurses, both NNU members and non-union nurses. I think certainly there is a lot of work to be done across the hospital, across healthcare settings, not just in the hospital around infection control. And there are certainly disparities between different types of settings. Hospitals have a little bit more attention paid to them. They're nowhere near where they need to be. But there's even less attention paid to clinics, to home health, right? To all of these other kinds of environments where folks work. And then in terms of solutions, like what is needed from my perspective, I think there's kind of two overall prongs to what's needed. One is improved regulatory protections with robust enforcement, and the other is union organizing and advocacy. So just, I think, briefly on the first prong on the regulatory protections, our members, CNA's leadership, who are all working registered nurses, have really looked at this issue. They've looked at the staffing crisis. And in particular, they've honed in on the need to have policies to retain experienced nurses. So there's a lot of conversation about recruiting new nurses, but that's not actually the problem here. Every year, the US graduates more new nurses out of nursing school than ever before. Actually, projections over the next decade are that we will not only replace the 500,000 RNs expected to retire, but we'll expand the workforce by almost 1 million new RNs. And so the reality is that we can't just keep letting employers run through nurses, discard them, injure them on the job, fire them, run them into the ground with moral distress. We have to make sure that those workers are taken care of, that they have a safe workplace, that they have an equal right to every other worker in this country. And so nurses have identified, a number of other policies that would be important to those safe working conditions, things like having a national safe staffing ratios law. California has had one for 2 decades now, and it had a massive improvement on nurse safety, on patient safety, on nurses returning to the bedside when it was passed 2 decades ago. certainly need that nationally now. Infectious diseases standards, workplace violence prevention standards, presumptive eligibility, making sure that nurses, we want to prevent injuries from happening, but making sure that nurses and other healthcare workers who do get injured have access to care. And then I think, thinking about robust enforcement of those protections also being key. And that can happen through the union structure. And that does happen every day through the union structure. That's why I think, protecting workers' right to organize is a really key piece of what's needed. But also making sure that we strengthen and feed our state agencies, like, for example, Cal OSHA. Our state OSHA plan here in California has had some really terrible struggles with staffing and management challenges over the recent years that has affected its ability to protect workers in the state. And so really, needing to build up those public institutions as well as a backup for workers, especially non-union workers who don't have access to the same kinds of protections that union folks do and can in their workplaces. So I think that's sort of an overview of what I would say is needed here.
Yes, thanks, Jane. And I just want to acknowledge the critical role that unions, healthcare unions in California played, including Jane and UNCNA and SEIU and a lot of the other unions that represent healthcare workers in advocating for and winning passage of the workplace violence and healthcare standard that we have in California, of improved staffing ratios. A lot of the improvements, the COVID regulation that we have in California, I can really directly, as I think Ed mentioned, I'm on the standards board, and I can directly say that the advocacy of those unions were critical to the passage of those. So thank you for your work in that area. And so now, Constanza, I wanted to ask if you have some, if you could share what your thoughts are about what are sort of the needs to protect against the hazards that you've described for us, or if there's particular things you're working on as a member of the negotiating committee. I want to give you a chance to share your thoughts.
Well, mainly is that we've been talking about staffing. Not just in my area. I mean, we're supposed to have 3 secretaries during the day, and we work 12 hours. And when somebody calls out, they don't bother to call anybody. They don't offer incentives, and we work 12 hours. So if they don't give incentives and they overwork us, nobody wants to come in. And I'm not gonna go take my break if I'm leaving one secretary for the whole ER. We have a large ER managing everything, because that is, they're setting us up for failure. You can have a HIPAA violation because you're overworked. You can delay patient care. And it's not just us, it goes across the board. It's the techs and the nurses. And I see everybody's exhausted. Everybody's like, this is not healthy for us as human beings when we're taking care of other human beings. So the main reason, the main subject we're gonna direct this is about giving us the breaks that we deserve, giving us the staffing that we deserve. And like I said, we're dealing with patients' lives, and we cannot put that at risk. We're all humans. There are times that I look at the staffing and I'm like, I wouldn't have my grandma over here today. And that's sad, because that's the organization I work for. So I should be vouching for it. Instead, sometimes I'm like, no, this is wrong. So it's just mainly the staffing. They have to offer the rifle pay and incentives for people to come in, the rifle breaks, the ones that we deserve, and make sure that we are taken care of, because if we're taken care of, the patients are going to be taken care of as well.
Thank you so much. So I think highlighting those important issues that everybody's been mentioning, staffing, but also things like breaks, and again, it impedes ability to provide decent care. So it really is linked to the quality of care and should provide an added incentive to make these kinds of changes. So thank you for sharing that. So Jessica, do you want to add your thoughts about what are some of the changes that we need to see?
Yeah, absolutely. So referring a little bit to Dr. Frogner, what Dr. Frogner was saying, a lot of this is needed at the policy level, because as much as we need these changes and at the individual facility level, we also need it on a much broader base. And we need Congress and state governments to support the changes and support especially with financing. So in terms of fixing sort of the payment structure and the low wages, we need new long-term care social insurance programs, especially through public-private partnerships. There needs to be extensive Medicaid reform. Also, we can do things like raise wages through wage pass-throughs and increase state Medicaid funding. Just a few weeks ago, the Ensuring Access to Medicaid Services rule was approved, which includes a measure that ensures that 80% of Medicaid HCBS payments go directly to direct care workers' paychecks. This rule will also mandate states to be more transparent about how much they pay for home care services and how they set their rates. And it mandates the creation of a home care rate setting advisory group that must consist of consumers and workers and other interested parties to advise and consult on that. So making sure that we're getting the direct input of those direct care workers who are on the ground doing this work. We can't, as many of us have said, we can't do this work without the direct involvement of those who are impacted by it. Other recommendations are federal training requirements. Like I said, there's only federal training requirements for home health aides and certified nursing assistants. There aren't any per se personal care aides. Also creating competency-based training infrastructure would help with that. In terms of lack of career progression, it would help to implement some job quality measures so that we are assessing what is the quality of this job and assessing how great of a job it is and will it attract people to the field, especially when we're talking about shortages. Other things in terms of workforce shortages are ways to directly match workers with consumers. So there's something, Washington State actually has a great one called matching service registries. And what these do is they basically connect a worker directly with those clients who need the care. And so take out agency middlemen. And so this was something that was passed by Washington's SEIU 775 union. And it really has led to Washington being one of the leading states that supports direct care workers in the home. And so they have higher wages, they make sure they're covered by health insurance, they get PTO, and they get more flexibility and control over their jobs and who they're working with. In terms of data, the recommendations are creation of a new updated minimum data set on direct care workers. There's a few initiatives working on this. PHI is one of a few organizations who are working with the National Council on Aging as part of initiative through the Administration for Community Living, or ACL, known as the Direct Care Workforce Strategy Center. They actually recently released their slate of states that they'll be applying technical assistance and direct technical assistance to. But we're hoping to sort of boost and improve data collection measures and recommendations through the work as part of that strategy center. And then finally, kind of the biggest hurdle that is something that is faced in every sector in our country is how do we address the systemic oppression and marginalization of workers, especially those who have been historically marginalized because of their race, their sex, or their immigration status. So first thing is pathways to citizenship, making sure that these workers can stay in the country, because we would not have a large part of this workforce without immigrants. Equity-centered interventions. So anytime we're implementing an intervention, looking at how it differentially affects different demographic groups. Will it affect women the same as it affects men? Will it affect white workers the same way it affects Black workers? So looking at those. Also implementing anti-bias trainings and being serious about them, not just a click through, not just something that's a checkbox, but something where those who participate in it have to show real competence in what they've learned about anti-bias training. Also, zero tolerance workplace policies for any sort of harassment or bigotry. We just can't afford to continue on with some of the negative racist, oppressive practices that we've seen in the healthcare industry.
Yeah, thank you, Jessica. Marnie, do you want to add your top level recommendations for change?
Yeah, and I mean, it's echoing some of these great examples. I think national or regulatory, mechanisms for change. We've seen some movement from the national level in terms of healthcare worker burnout reports during, as a result of COVID from the U.S. Surgeon General's office. Recently, OSHA has put up a page on the impact of work stress and what resources are available in terms of identifying these problems. And I think the biggest thing is to connect up working conditions with work stress so that it's not seen as this individual problem, which is oftentimes what employers do to working people. Is if you can't cut it, you're the weakness, whereas I think raising awareness about the fact that stress is something and that related to working conditions, related to the actual way we organize work, for example, with understaffing that's due to lean production. The private sector in healthcare obviously has been doing this for decades, is just not hiring the people that are needed to provide healthy and safe work for healthcare workers and also for patient safety. That has to change. I think the public sector is faced with a lot of different challenges for their, workers in healthcare and public health, the budget constraints from the state level, helping, provide salaries that are competitive for public health workers and health and community service workers in, rural areas or, non-urban areas is really important. And again, I think, we're looking towards making the case for the impact of these working conditions on worker health and including in terms of burnout and turnover, which is obviously a concern for nurses. We know nurses leave the field, as Jane has talked about, within several years of being overworked and facing those kinds of turnover rates, needs to be dealt with. And I think policy around ensuring worker mental health is something that could be organized around across different healthcare sectors. And then I guess we as a Healthy Work Campaign fully back union organizing and collective bargaining contracts that incorporate language to deal with things like workplace bullying, to deal with equity issues around working conditions, and also to really think about and consider workload issues and ways of really working together to put pressure in this public sector on counties' budgets, on the state, for a proper coverage and reward for healthcare workers, because I think that's something that obviously is going to make a huge difference. Although I think workloads and understaffing are probably more of a concern than pay for workers in some cases. And then finally, we do work with employers at times who are concerned and have made some, connection between their loss of a lot of workers during COVID and continuing, and their ability to provide care, to their communities, to their patients, and so on. And although they may be few and far between, there are, at least with our example, working with this Health and Human Service Agency that started with management, they actually ended up reaching out and bringing their unions on board, and have actually, redone the survey to see how they did over the first 12 months to see if what they've put into effect was effective. And I think that kind of commitment to looking at the problem, on an ongoing basis annually, and having better labor management relationships, creating labor management partnerships, and involving employees in the decision making and in the contributing their experiences with these issues, can have a big impact on towards change. So I'd like to see more and more of that happen.
Thank you. So Dr. Frogner, we're going to probably be coming to you as our final word on this. We've got about 5 minutes left of our session. And I want to make sure there's another question that came in before I turn to you, just to see if this might inform what you might say. which is some states like California rely heavily on the independent provider model in which service recipients directly employ caregivers, but this means that some traditional functions and responsibilities fall to the wayside. So the question would be, I'm going to first start with you, Dr. Frogner, to give you your recommendations, but if we can have others weigh in too. Do you have any thoughts on the differences between the independent provider versus the agency model for providing care in terms of the incidents or remedies for harassment and abuse? So I just want to put that question out there while we have probably about 5 minutes left. But do you want to add any comments on that, as well as your other thoughts on what is needed?
Yeah, I think that the question might be best answered by, I'll throw it to Jessica, maybe as a potential person who could potentially answer that question. But I do just want to stress a couple points that I'm hearing here that I would certainly put on my list, which is, as Jane mentioned, recruitment is probably should be less of a priority than retention. We're not going to solve our way by producing more people. We have a lot better chance to improve our supply of workers by focusing on the well-being of our workers who are currently in place and keeping them in their jobs for as long as possible. That is certainly the better strategy. You can't replace an experienced nurse, for example, with a brand new nurse. That's just not an equivalent metric there. And I think part of that is addressing workplace violence, which has certainly surged over time, and we need to prioritize that. And I'm encouraged that there is national attention of that through the Surgeon General's office, through the White House, through the Department of Health and Human Services. But we really need to think very comprehensively about our healthcare system. And I think that's a key thing, is that we can't just help one sector of the healthcare economy at a single point in time. What happens in nursing homes affects hospitals. What happens in hospitals affects nursing homes. Like, they're all intertwined. And so we need to think holistically about the healthcare system and then the workers in them, because I think one of the challenges we feel around burnout among physicians and nurses is somewhat driven by the fact that there's so much turnover in the support staff around them. And so as a result, many of the workers are finding themselves taking on jobs and work that they're like, this is below my scope of practice. This is not what I was trained to do. This is not what I should be paid to do. It's not a great way for employers to go, is to use their very highly trained workers in ways that doesn't really make sense relative to their training. So we need to be thoughtful about that. And I mean, that's, I think, what everyone's kind of saying by saying we need to make sure we're caring for our workers, making sure that we have the right regulations in place to keep our workers safe. But part of that is also making sure that people are practicing within their scope to the top of their license, not limiting that either. And we need to really expand that scope. And we tried a lot of interesting things during the pandemic, but we haven't really spent a lot of time evaluating to see what works. And we're just rolling back changes or making all sorts of changes in these last few years without spending much time evaluating what's working and what's not. So we need to do more evaluation of that. I think that one piece that I think somewhat underlies that question that came in is there's a element that there's a lot of third parties in healthcare that is interfering with our ability to make changes quickly or nimbly. I think among that is third-party payers like insurance. They certainly don't make it easy for us to quickly increase wages for someone, because it's a whole process behind changing policies around payment in order to make that happen. And added to that is the privatization of healthcare and the growth of private equity within healthcare that is leading to disruptive closures of pharmacies, of hospitals, skilled nursing facilities, that is really disrupting the job market. And trying to figure out how to allow patients more direct access to the kind of care that they need, to the people that they need, is something we do need to prioritize. And I think part of that is just thinking about what do the patients need and how do we orient a healthcare system and the healthcare workforce in a way that allows the healthcare worker to really have some control over what they do in a way that allows them to best care for the patient.
Thank you. And Jessica, maybe I'll see if you have maybe just a really quick response to that question, and then we're going to have to wrap our panel up. But I'll just give you an opportunity. I know you've been looking into the long-term care workforce.
Yeah, thanks so much, Laura. So yeah, it's a great question asking about the independent provider model versus the agency model and ways to address harassment and abuse. And certainly neither of them is a perfect model. I think there's a place for the agency model because there is more oversight, there's more direct supervision and direct training that way, and someone to call when you have an issue. Part of the issues we've seen with the independent provider model is that the worker feels alone, and when there is an issue with a client, there isn't somewhere or a number to call or a way to address it. And so we haven't done direct research on this, the agency versus independent provider model in terms of harassment and abuse. But that's definitely something that's on our minds about how we address this so that we're not leaving healthcare workers, especially, I mean, direct care workers, especially home care workers alone in the home without supports. So that's definitely something that we're looking at and thinking about.
Yeah, and maybe I'll add one thing. I know at LOHP, I was involved with a project that looked at home care workers for many years, and we worked with independent providers and people as part of the in-home supportive services. And I will just add that another challenge is those workers are often excluded from basic workers' rights. They're not considered employees, and therefore they don't have access to a whole host of rights that people have when they're working within agencies, kind of similar to the independent contractor model and all the problems we've been discussing associated with that. So I'll just add that one other challenge. But with that, I really want to thank everyone. I was thinking how I might summarize this excellent discussion, and it's fairly impossible. But it's a huge workforce. The issues are incredibly complex. I really appreciate the connection of what's happening in the workplace that many of you made to broader issues around healthcare for profit and the impact of race, gender, immigration status. I really appreciate the focus that people made on really being engaged directly with workers and unions to get, the guidance about what's needed. So this was really, really valuable. So thank you so much for participating in this conversation. And thank you for the work that you're doing, that you've done, and that you continue to do to advocate for better working conditions for healthcare workers. So with that, I'm going to thank you and turn it back over to Ed.